Hello everyone. Welcome back to the series of lectures in neurology. Today we will be starting off with a very important topic, which is your approach to spinal cord. So in this chapter we will be looking at some of the applied anatomy and clinical aspects and how do you localize a spinal cord lesion. So let's begin. So what is the spinal cord? The spinal cord is basically a conical structure which is the continuation of the medulla, and it terminates at the level of L1 or L2 vertebra, right? So it terminates at the level of your L1 or L2 lumbar vertebra. Okay, so there are certain important terms which you should be understanding when it comes to the spinal cord. So what is phylum terminale? So once the spinal cord ends at the level of L1, then the rest of the coverings of the spinal cord extend downwards, and this is what we call as phylum terminale. So the extension of the pia mater down after the spinal cord ends is called as the phylum terminale. So this is the extension of the pia. Then when the spinal cord terminates at the level of L1, when the spinal cord terminates, it tapers down into a conical structure that we call as conus medullaris. So conus medullaris is basically a conical structure as the spinal cord terminates down at the level of L1. So this is present at the vertebral level L1 and L2, but the segments which are present within it are S2 and S3. Okay, so this yellow highlighted portion is your conus medullaris. Why is there a difference between your spinal level and your segmental spinal segments and your vertebral level? Because there is a difference in the growth of the spinal cord. The spinal cord goes slowly, but the vertebrae grows faster, and hence there is a difference in your spinal segmental level and your vertebral level. What is the cauda equina? So can you see that there is a bunch of nerves which arise from the lower end of the spinal cord, and this is similar to the horse's tail. So this is what we call as cauda equina, which means that the terminal portion of the spinal cord, which comprises of a bunch of nerves which is similar to a horse's tail, is your cauda equina. So it comprises of L1, L2, L3, L4, L5 nerve roots which come out together and form a bunch which is called as cauda equina. Okay, so this is about the basic anatomical properties which you should know: phylum terminale, conus medullaris, cauda. Also understand that there are 31 pairs of spinal nerves, but the vertebrae are only 30 in number. This is because of a differential development of the spinal cord and the spinal nerves. The vertebrae actually develop faster, whereas the spinal cord develops slower, and hence the number of nerve roots in the spinal cord is slightly more than that of the vertebral column. Okay, so what are the number of spinal nerves? We have 8 pairs of cervical nerves, 12 thoracic, 5 lumbar, 5 sacral, 1 coccygeal. So you can see that there are 7 cervical vertebrae. The number of vertebrae are only 7, but the number of nerve roots in the cervical cord are 8. So from the spinal cord we have nerve roots which come out like this. Okay, these are called as the spinal nerves. Okay, so the number of spinal nerves is slightly different from the number of vertebrae. What are the functions of the spinal nerves? These nerves basically go out, branch out and supply the upper limbs and the lower limbs. They can also supply the thorax and the genitalia, right? So they supply the thorax, the genitalia, the bladder, and they are involved in the bowel function as well. So this is the basic function of your spinal nerves. Okay, alright. Another important anatomical consideration is that the first 7 pairs, the first few pairs of nerves basically go out above the vertebrae. Okay, fine. So if this is your vertebral column, so this is your C4 vertebrae and the C5 vertebrae. Then the C4 nerve root comes above. The C4 nerve root comes above the level of the C4 vertebrae. But when it comes to the other spinal nerves, not your upper cervical, the other spinal nerves, they basically come below. They come below. Okay. So if you are taking a T2 nerve root, right? So this is the T2 vertebrae, this is the T3 vertebrae. The T2 nerve root comes between T2 and T3. But a C4 nerve root comes above C4, that means it comes between C3 and C4, right? So it's coming between C3 and C4 or above C4, whereas the other lower nerve roots come below the level of the corresponding vertebrae. Okay, So this is why whenever you describe a spinal cord lesion, you need to tell at which level the lesion has happened. For example, you have a tumor which is compressing on the spinal cord. This type of an injury is called as a compressive myelopathy. We will be talking about compressive versus non-compressive a little later on. Okay. So let us understand that we have a tumor which is pressing on the spinal cord, and this is causing a compression of the spinal cord. Now we need to know at which level of the spinal cord is the tumor compressing, right? So that is what we call as the level of the lesion, and that is how you describe a compressive myelopathy. Now whenever you describe the level of the lesion, you have to describe it in terms of two levels which are called as the vertebral level and the spinal level. Why are there two levels? Because there is a differential growth of the spinal cord and the vertebral column, and hence you will get two levels, which is your vertebral level and the spinal level. And whenever you describe a compressive spinal cord level, you will learn it in your post-graduation as well. So whenever you describe a compressive myelopathy, you have to describe it in terms of a spinal level and a vertebral level. Spinal level means that at which cord level it is pressing. Vertebral level means that at which vertebrae it is pressing because of the differential growth. So let us understand the relationship between your vertebral level and your spinal level. Always remember that the vertebral level is always higher. Okay. So when we look at the upper cervical vertebrae, let us see in this image, right? So the upper cervical vertebrae are your C2, C3, C4, right? So C1, C2, C3 and C4, the nerve roots come from above, right? They come from above the corresponding vertebrae. The C3 nerve root is going to come from above the C3 vertebrae. C4 nerve root is going to come above the C4, right? So in your upper cervical cord lesions, if suppose there is a tumor pressing over here, okay, and you want to tell the level at which the tumor is pressing, then in your upper cervical vertebrae, the level at which is going to press the spinal cord and your vertebral level is going to be the same. It is only as you come downwards in your lower cervical, thoracic, lumbar vertebrae that the levels are going to change. Okay, so let us look at it here. In your lower cervical vertebrae, okay, what do you mean by that? Now, when you are examining a patient with paraparesis, what have we learned the basic in a spinal cord lesion? He will have weakness, right? So if there is a compression at any level in a spinal cord, or if there is an injury to the spinal cord at any level, he will have weakness below the level of lesion. He will have loss of pain and temperature below the level of lesion because of damage to the corticospinal tracts and damage to the spinothalamic tracts. Okay. So the level of lesion, how do you know it? So when you examine it, you will see the level of lesion. At the level of lesion, he will have a band-like sensation, and below that he will not have any sensations, he will have weakness. So how do you know this is which level? So you will ask the patient to turn over and count at which vertebral level this problem is starting, right? So if you examine for pain and temperature, there will be a point where above which he is able to feel the pain and temperature and below which the pain and temperature is lost. Or similarly, above which he is able to move. For example, he is able to move his hands but not able to move his leg. Then you need to find out at which vertebral level the problem is. So you ask the patient to turn over and start counting at which vertebrae the problem is. So that is what we call as the vertebral level. So at the lower cervical vertebral level, okay, for example, here at the level of your C7 vertebra, at the level of your C7 vertebra, okay, what is the spinal cord level or spinal nerve root which is injured at that level? You have to add 1 to that. So C7 plus 1 is C8 nerve root. So when you count it, it may be at the level of C7 vertebra. But that doesn't mean that the cord level is your C7. You will have to add 1, right? That is because there is a difference in the number. Number of vertebrae are 7, number of nerve roots are 8, and there is a differential growth. That is the reason why you should be knowing this. So at the level of C7, can you see that which level is of the spinal cord is affected? 1, 2, 3, 4, 5, 6, 7, 8. So it is C8 cord level, right? So C7 vertebra is C8 cord level, lower cervical at 1. Okay, this is very, very clear. Then thoracic vertebra 1 to 6, we add 2. Okay, that means what? At thoracic vertebra number 2, the cord level, the expected cord level has to be around 4. Okay, the cord level will be a segment 4 or the nerve root 4. Let us see that. For example, this is your thoracic cord number 2. And can you see at the level of 2 which spinal cord segment is affected? So you can see 1, 2, 3, 4. So around 3 to 4 nerve root, 3 to 4, thoracic 3 to thoracic 4 nerve root is the one which is getting compressed. So you add 2. So thoracic 1 to 2 you add 2, thoracic 7 to 9 you add 3. So for example, let us see the T7 level. What will be the spinal cord level? T7 vertebra. When you examine like this and count which vertebra the defect or the neurological deficit is, you are getting at the level of T7. Okay, then what is the spinal cord level, or which level is the nerve root is getting compressed? Then you will have to add 3. So for example, this is your thoracic 7 vertebra, and you can see that this nerve root is getting compressed. So you can count 1, 2, 3, 4, 5, 6, 7, 8, 9. Right? So around the 9 to 10. Right? You will have to add 3, but it's not a hard and fast rule. So around T9 to T10 will be the cord level. So you will have to add 3. Okay? Understood? So this is how we are going to find out the cord level and the vertebral level. Just it might be difficult initially, it might appear confusing, but this is something if you go through twice and examine some patients, you will understand what is the difference between a vertebral level and cord level. At the level of T10, remember these numbers are easier to remember. T10 you remember L1, L2, T11 is at the level of L3, L4. So for example, T10 is this thoracic cord. This is your thoracic cord T10, right? So this is your thoracic cord T10, and can you see that your L1 is almost present at that level. The nerve root which is passing here is your L1 nerve root. Okay, so T10 at the level of L1, T11 L3, L4, T12 is L5, and L1 vertebral level is corresponding to your sacral and coccygeal levels. So can you see that L1 you already have your sacrum and coccygeal levels, nerve roots which are coming out. Okay, fine. So this is your relation between your vertebral level and cord level, and remember the vertebral level is usually higher. Fine. Okay, so to vertebral level, to find out the cord level, you will have to add, depending upon the numbers, lower cervical you will have to add 1, so thoracic you will have to add 2, and so on and so on. Okay, so T10 vertebrae is at the level of L1 spinal cord. Okay, clear. Now let us understand the lamination of the tracts in the spinal cord, right? So first of all, what are the different types of tracts that you can see? Okay, so we have the first and the most important, the pyramidal tract, which is your corticospinal tract. So we have a uncrossed corticospinal tract and the crossed corticospinal tract. The uncrossed corticospinal tract, as we had learned in our basics on approach to stroke as well, it is very minimal percentage, only 10% of the tracts. Most of the tracts of your corticospinal tract has crossed in the medulla. It has crossed in the medulla and it has come to the lateral corticospinal tract in the spinal cord. Right? Fine. So this has already crossed in the medulla. Okay, fine. Then what are the other tracts? Then we also have your lateral spinothalamic tract and the ventral or the anterior spinothalamic tract. Lateral spinothalamic tract is basically involved in the understanding of pain and temperature. So lateral spinothalamic tract carries pain and temperature, and anterior spinothalamic tract carries pressure and touch. Okay, so pain and temperature is carried by the lateral spinothalamic tract, and pain and pressure and touch is carried by the anterior spinothalamic tract. Then we have the posterior column, which is your fasciculus cuneatus and fasciculus gracilis, which are involved in carrying your joint position and vibration sense. Apart from that, we have your spinocerebellar tracts, and we also have your rubrospinal and reticulospinal tracts. Rubro and reticulospinal tracts. So the rubrospinal tract is involved in coordination of distal limb movements. Reticulospinal tracts are involved in the coordination of axial and proximal limb movements. Okay, fine. So these are the various tracts and what do the tracts carry. This we have discussed. in our previous chapter on approach to stroke as well. Okay, so what are the major tracts that you should know? We have the corticospinal tract, which carries the motor functions. The corticospinal tracts are already crossed in the medulla, so they are going to carry the motor functions. Okay, so this is a descending tract. Your ascending tracts or your spinothalamic tracts, the lateral spinothalamic tract, which carries pain and temperature from the body, and your anterior spinothalamic tract, which carry minor touch and pressure sensations. The vibration and proprioception sensations are carried by the posterior column. And remember, the lateral corticospinal tract carries the crossed fibers. If you go back and look at the tracts of which we had discussed in our stroke chapter, that your spinothalamic tracts cross at the level of spinal cord, right? So they are going to carry the pain and temperature sensations from the contralateral side of the body, whereas the posterior column, which is your fasciculus, gracilis and cuneatus, which carries your vibration and proprioception sensation from the body, is not going to cross in the spinal cord. So it does not have any crossing in the spinal cord, and it just carries your ipsilateral sensations. Okay, clear? So this is about the various tracts. Within this tracts itself, you should know about the lamination of the tracts, right? So you have to understand that within your corticospinal tract, the cervical fibers are present medially and the sacral fibers are present lateral most, right? So within your corticospinal tract or spinothalamic tract, the cervical fibers are present medially and sacral fibers are present lateral most. What does this mean? Right? So whenever there is a relay, okay, these regions, the nerve fibers from the cervical column are going to come and laminate like this. Then the nerve fibers from the thoracic are going to come and laminate this way. Then we have the cervical, thoracic, lumbar and the sacral fibers which come like this. So from medial to lateral, we have the cervical, thoracic, lumbar and sacral. Similarly, if you look at the spinothalamic tract, what is going to be medial most? Okay, so the pain and temperature from the cervical region, the pain and temperature sensations from the cervical region, let us say from the left side, is going to cross over in the spinal cord to the right side and going to go this way. Okay, fine. So this is medial most. The pain and temperature from the thoracic region is going to cross over this way, right? It's going to cross over to the opposite side and it is going to come next to the cervical tracts. So this comes laterally. So you can see that the medial most fibers are going to carry the cervical pain and temperature sensations. Lateral is by the sacral. Okay, right? So can you see here with this diagram, this is your cervical, this is your thoracic, this is your lumbar, this is your sacral. So pain and temperature, we are talking about the spinothalamic tract. So pain and temperature going to cross and this is going to come like this. This is your cervical and it's carried by the spinothalamic tract. At the thoracic level, again the fibers are going to cross over and they are carried laterally. Then, okay, then cervical, thoracic, then lumbar. Lumbar fibers are crossing over and carried like this. Okay, then sacral fibers are crossing over and carried like this. So can you see the arrangement? The medial most is C, T, L, S. This is what we mean by the lamination of the tracts. So the medial most fibers are cervical, lateral most fibers are sacral in both your pyramidal tracts and your spinothalamic tracts. Okay, remember this, very important, because based on this lamination only you will know the differences in your different patterns of weakness and different types of myelopathies. But let us look at the posterior column. How are the posterior column sensations slightly different? Because here there is no crossing over. Hence, the vibration and proprioception fibers. The vibration and proprioception fibers from the cervical will go like this. Then the thoracic goes like this. L and S. Okay, that is why there is a slight difference. Okay, so please have a picture memory of the lamination of tracts here. Another very important point that I want to stress about is bladder fibers. You will think that the bladder fibers are going to be present laterally because the urinary bladder is going to be supplied by the sacral segments of the spinal cord, right? Then the S, which is present laterally, is going to get affected first. But No. What happens is that in the spinal cord there is a separate center for bladder innervation which is actually present medially. So do not get confused that bladder involvement will happen earlier when there is a compression from outside. No, that is wrong, because the bladder innervation is actually present in a separate site medially, and it is not through these S segments, that is only your pain and temperature, it is not your bladder innervation. Okay, clear? Fine. So this is about the lamination of the various tracts. So first, let us look at the implications of this crossing over and the different types of tracts. Okay, now the spinothalamic tract. Now the spinothalamic tract at the level of the spinal cord is going to cross to the opposite side and then go upwards, right? So any lesion which is going to affect one half of the spinal cord, if there is a hemisection of the spinal cord, then how will you have your pattern of pain and temperature loss? The pattern of pain and temperature loss is going to be contralateral. It causes contralateral pain and temperature loss because the crossing over takes place in the spinal cord itself. So compression from one side, then opposite side is affected. Then corticospinal tract. Corticospinal tracts, if there is going to be a hemisection, it is already the crossed fibers. The fibers have crossed at the level of the medulla. So it causes ipsilateral weakness. So it causes ipsilateral weakness if there is a hemisection of the spinal cord. So there is ipsilateral weakness and contralateral hemisensory loss. Not hemisensory loss, contralateral sensory loss. Okay, and the corticospinal tract predominantly is going to innervate the extensors. So it innervates the extensors of the upper limb and flexors of the lower limb. Then we'll understand what are the functions of the rubrospinal tract and the reticulospinal tract. Okay, so the rubrospinal tract is going to innervate the contralateral flexor muscle tone of the lower limb. The reticulo and vestibulospinal tracts are going to affect the axial muscles and the ipsilateral extensor muscle tone. Okay, so reticulo and vestibulospinal tract affects the ipsilateral extensor muscle tone, and the rubrospinal tract is going to affect the contralateral flexor muscle tone. So if there is a damage, right? So if there is a damage and the rubrospinal tract is intact, the reticulospinal tract is lost, then what happens? The rubrospinal tract is going to increase its innervation to the flexor muscles, and hence you will have paraplegia in flexion. Rubrospinal tract will increase its innervation to the flexor muscles. You will have paraplegia in flexion, right? That is why there is a difference between paraplegia in flexion versus paraplegia in extension. Okay, understood? So this is about the various tracts and innervations and how is it different from one another. So this is a very, very important and often considered to be difficult concept in your spinal cord. So let us understand the blood supply of the spinal cord before we try and understand the various spinal cord syndromes. Okay, so the blood supply of the spinal cord is brought about by the spinal arteries. So the vertebral artery gives rise to one anterior spinal artery and two posterior spinal arteries. Okay, so the vertebral artery gives rise to one anterior spinal artery and two posterior spinal arteries. The anterior spinal artery supplies the anterior 2/3 of the spinal cord and posterior 1/3 is by the posterior spinal artery. Okay. Apart from this, we have radicular arteries which are 3 in number. Radicular arteries, as the name suggests, supplies the radical or the spinal roots. Then we have the artery of the Adamcevics, which is direct branch of the lumbar artery, and it supplies the T8 to L3 segments of the spinal cord. Okay. Now let us understand what are the signs and symptoms with which a spinal cord lesion presents. Okay, so each and every word is very, very important. So the first sign of a spinal cord lesion is the presence of a weakness. What type of weakness will a spinal cord lesion result in? It results in a UMN, an upper motor neuron type of lesion. Okay, please remember that in the initial stage of spinal cord injury, you can have an element type of weakness. In the initial stage of spinal cord injury, you can have an element type of weakness predominantly because of the presence of spinal shock. Presence of spinal shock where all the spinal cord is in shock because of the injury, you can have a complete element type of weakness, but as the spinal cord injury progresses, you will have a UMN type of weakness. Okay, so you will have spasticity, right? Okay, fine. And the spinal cord injury will cause what type of weakness? It can cause paraplegia, quadriplegia or monoplegia, right? Depending on how much extent of the corticospinal tract is going to get involved, right? So in our chapter on approach to weakness also we had learned that if there is a UMN lesion at the level of the cortex, it is going to cause a hemiplegia, right? So a stroke is always going to cause a hemiplegia, right? So hemiplegia is associated with cortical lesions or lesions in the brain. Okay, but spinal cord lesions, because the spinal cord is, if it is cut here, then it is going to only affect the corticospinal tracts that it supplies below the level of, correct? It's not going to affect the corticospinal tract above. So it can cause paraplegia where both the limbs are involved, monoplegia where one limb is involved, or quadriplegia, especially in cervical cord lesions where both the hands and legs are involved. Okay, fine. Now you see, if there is a hemisection, of the spinal cord, we already have the crossed fibers of the corticospinal tract, so it will cause ipsilateral weakness. So if there is a hemisection of the spinal cord on the right side, it will cause a right monoplegia. Okay, if there is a complete transection, of the spinal cord, then it is going to cause paraplegia. Okay, clear. Now this is about the weakness. The second and the most important sign is the presence of a definite sensory level. What do you mean by a definite sensory level? Definite sensory level means the patient himself, if he is aware of what is happening, he will say that there is a level below which there is a complete, in case of a complete transection, there is a loss of pain, temperature, proprioception, vibration, right, and weakness will be present. There is loss of every sensation below the level and everything else is preserved above the level, and this is what we call as a definite sensory level. The level below which there is a complete or incomplete, depending upon the degree of injury, loss of pain, temperature, proprioception, vibration and presence of weakness below the level of lesion. Presence of a definite sensory level is one of the most important signs which helps you localize a weakness to a spinal cord lesion. Then what happens to the reflexes? Always remember, in a spinal cord lesions, at the level of lesions you will have LMN signs. At the level of lesion you will have LMN signs or low motor neuron signs. So you will be loss of reflexes at the level of lesion. Below the level of lesion, you will have UMN signs. You will have exaggerated reflexes below the level of lesion. At the level of lesion, LMN signs. Below the level of lesion, UMN signs, exaggerated reflexes. And a very, very characteristic feature of spinal cord involvement is bowel and bladder involvement, because it is the spinal cord nerve roots which supply your bowel and bladder. Okay, so whenever you have a weakness, how do you localize to the spinal cord is the presence of paraplegia, monoplegia, quadriplegia. It is not that your brain lesions cannot cause paraplegia or monoplegia, right? We have learned in an unpaired ACA territory stroke, you can have paraplegia, but they will have other symptoms as well. Here, how will you localize to the spinal cord? Presence of definite sensory levels, exaggerated reflexes below the level of lesions, and bowel and bladder involvement. So these are the definitive signs of spinal cord involvement. Okay, fine. Now let us understand the patterns of spinal cord syndromes. Okay, so in complete transection of the spinal cord, what will you get? So you will get a paraplegia if there is a thoracic cord transection. If there is a cervical cord transection, then you will get a quadriplegia. And you will have a complete loss of sensations, because bilateral spinothalamic tract, bilateral corticospinal tract are lost at the level of the lesion. So complete loss of pain and temperature, right? And you will have a definitive bowel and bladder involvement. Okay. Now, What is Brown-Séquard syndrome? This is hemisection of the spinal cord. So if the spinal cord is cut into half, like for example following a road traffic accident, you have hemisection of the spinal cord. So when you have a hemisection of the spinal cord, what is happening? This is your corticospinal tract. This is your corticospinal tract, right? And you have the spinothalamic tract and you have the posterior column. Okay. So if you have a hemisection of the spinal cord, right? So what will happen? You will have ipsilateral. Okay, so you have a right-sided hemisection. On the right side, you will have loss of corticospinal tract, right? So you will have weakness. And what else is there ipsilaterally? You know that the posterior column fibers do not cross at the level of spinal cord. So you have ipsilateral loss of vibration and proprioception. Ipsilateral loss of vibration and proprioception because of damage to the posterior column. But you have the crossed fibers of the spinothalamic tract which are not going to be affected. So you have the crossed fibers of right-sided spinothalamic tract, right? So you have the crossed fibers of the right-sided spinothalamic tract. So what will happen? You will have a contralateral hemisensory loss. Okay, ipsilateral loss of corticospinal tract, so ipsilateral weakness, ipsilateral loss of vibration and proprioception, and contralateral hemisensory loss. So sensations are lost on the opposite side, but the weakness is on the same side. Okay, so weakness is on the same side and sensations are lost on the opposite side. This is your Brown-Séquard syndrome. Okay, why is this happening? Because the crossed fibers of the spinothalamic tract are affected. Then anterior cord syndrome. Anterior cord syndrome, where will you get? For example, if there is an embolus into the anterior spinal artery. There is an embolus into this anterior spinal artery. Then what will happen? Then your anterior 2/3 of the spinal cord will be affected, but the posterior 1/3 will not be affected. The posterior 1/3 will not be affected. Posterior 1/3 is by posterior spinal artery. That means which fibers are not affected? Proprioception and vibration will not be affected. Okay, proprioception and vibration will not be affected. Similarly, in a posterior cord syndrome, it is only the proprioception and vibration will be affected because it is only the posterior spinal artery which is affected. Then the next type is your central cord syndrome. Okay, in a central cord syndrome, for example, in your syringomyelia, you have a cavity which is present within the arising from the medulla of the spinal cord. So we have an intramedullary lesion or a tumor which is arising from the central cord, right? So this is called as a central cord syndrome. So in a central cord syndrome, what are the structures which are going to get affected first? It is your cervical fibers and your sacral fibers are going to get affected last. Can you see that the expansion is this way? Okay, and the posterior column is not at all going to get affected, right? So corticospinal tract and spinothalamic tract involvement can happen in an intramedullary lesion. Posteriorly, it extends last, so that can be spared, and hence you have a dissociated sensory loss where you have loss of pain and temperature. You can have loss of pain and temperature, right? But the proprioception is not lost and it occurs in a cape-like distribution. Cape means what? You wear a cape over your shoulders, right? So shoulders and cervical region is affected first. Sacral regions are affected last because of this lamination where cervical is present medially, sacral is present laterally. Okay, so this is very, very clear about the different patterns of spinal cord involvement. So if you understand the basics and lamination of the tracts, this becomes very, very simple. Okay, so this is clear. Now, let us understand how do you localize the level of lesion, right? So I spoke to you briefly about what is the meaning of level of lesion, right? So if you have the spinal cord lesion and there is a tumor or maybe an abscess or an infection which is compressing on the spinal cord, you need to know at what level the deficits are starting, above which there are no deficits, and that is what is known as the level of lesion. So how do you localize the level of lesion? The uppermost level of a spinal cord lesion, which is characterized by segmental signs. What are the segmental signs that you should be knowing? So a patient who is aware of what is happening will complain of a band-like sensation, because at that level He has a band-like sensation below which there are no sensations, above which all the sensations are intact. So, presence of band-like sensations. Second, at the level of lesion, we know that in a spinal cord lesion, at the level of lesion, element signs. So, you will have element signs at the level of lesion. Element signs at the level of lesion. Right? So, the presence of element signs at one level indicates that this is the level at which the compression or injury is taking place. Okay. So, this is characterized by segmental fasciculations or atrophy. Okay. For example, let us say that the compression is taking place at the level of C5, C6. Okay. We know that the C5, C6 is going to be the nerve supply of which muscle? It is your biceps. Okay. So, you will have element changes at the level of C5, C6 and UMN changes below that. So, what will you look for element changes? You will see that there is atrophy of that biceps muscle, right? Okay, you will have atrophy, you will have fasciculations along that dermatome and atrophy of that particular muscle. So, that is a very important localizing sign to your level of lesion. Third, you can have sensory loss or autonomic disturbances or motor impairment below the level of lesions. So, you can have UMN signs, you can have complete sensory loss or partial depending on how much of the injury has taken place, autonomic disturbances or motor impairment below the level of lesion. So, this is about how do you localize your level of lesion in the spinal cord. Okay, clear. Now, we will look at certain signs which we can see to identify at which level the problem is. It need not always be a compression, it can be a non-compressive myelopathy, it can be inflammation of the spinal cord, right? It can be anything. So, at which level a particular neurological deficit is happening and which level the lesion is, how do you localize that, we will see. So, if the lesion is at the level of a cervical cord, okay, so if the lesion is at the level of the cervical cord, lesion is here, then what type of weakness you will have? You will have UMN signs and weakness of all the limbs below. So, you will have quadriparesis. Paresis means weakness, plegia means complete weakness. Paresis or plegia depending upon how much injury has taken place. Okay. So, you can have quadriparesis or quadriplegia. Okay. So, every time that we speak about a spinal cord lesion, we have to talk about the weakness, we have to talk about the sensations, we have to talk about the reflexes, we have to talk about the special features. Okay. So, what type of weakness? You will have quadriparesis or quadriplegia and you will have complete loss of pain and temperature sensation below the level of lesion, that is okay. Then, what will be the reflex changes? Okay, so if the lesion is at the level of, if the lesion at C5, C6, then what will be lost? Your reflexes should be lost at that level because you will have element changes at the level of lesion and UMN changes below the level of lesion. So, biceps supinator will be lost because biceps supinator, what is the jerk level? The biceps and supinator reflex level is C5, C6. So, if the lesion is at the level of C5, C6, biceps and supinator will be lost, but triceps, which is below because it is supplied by C7 and it is supplied by C7, C8. So, triceps will be exaggerated. Clear? Very, very important. Please don't get confused. So, at the level element, below the level UMN, please chant it 3-4 times, you will understand. Okay. At the level element, reflexes will be lost. Below the level UMN, reflexes will be exaggerated. So, at the level of C5, C6, if there is a lesion, biceps supinator lost, triceps exaggerated. Then, at the level of C7, C8, that means triceps will be lost and there will be weakness of small muscles of the hand and biceps will be intact. Why? Because biceps is by C5, C6, above the level reflexes will be intact. Okay, fine. Another special feature is that the sympathetic chain, we had learned this in your brainstem syndromes also, sympathetic chain can come down up to the cervical cord. Sympathetic chain is present there, any lesion there can cause damage to the sympathetic chain and result in Horner's syndrome. It can result in Horner's syndrome characterized by ptosis, meiosis and loss of sweating on the ipsilateral side. And the eye becomes smaller, there is enophthalmos. Then, if there is a C3, C4 lesion, there is also a chance of diaphragmatic injury and they can go into respiratory paralysis because the diaphragmatic nerves also arise from there. Clear? So, this is about your cervical cord. You will have quadriplegia, you will can have diaphragmatic involvement and you can have your different kind of reflex changes. Thoracic cord, how will be the weakness? You will have paraplegia or paraparesis and loss of sensations or accordingly. Sensory level at T4, T5. Sensory level at T4, T5. Now, can you see in this diagram? So, T4, how do you localize it? It is present at the level of nipples. So, at this level, you will find LMN signs, and below this level, you will find UMN signs. Okay. So, below the level, if you are finding UMN signs in a UMN pattern of injury, what will happen to the reflexes? The deep tendon reflexes are exaggerated, whereas the superficial reflexes will be lost. Okay. So, what is the level of your superficial reflex here? What will you find? You will find the abdominal reflex. So, the abdominal reflex is lost, but your knee jerk, ankle jerk, everything will be exaggerated because your knee jerk is L2, L3, L4 and ankle jerk is S1. All of these are below, so they will be exaggerated. Okay. So, if the lesion is at the level of T4, T5, abdominal reflex is lost. Okay. Also, we know that from the thoraco and lumbar regions, we have the thoracolumbar outflow, which is your sympathetic tract. Okay. So, there can be an autonomic dysfunction, sympathetic dysfunction can be there, and hence, so because of this damage or there is excessive sympathetic dysfunction, you can have resting tachycardia, sudden shoot up in the blood pressure and lot of sympathetic dysfunction. Okay, clear. Then, if the level is below, if the level is at the level of T10, if the level is at the level of T10. Now, let us see at which level. T10 is at the level of the umbilicus. T10 is at the level of the umbilicus. So, what happens above, right? So, when we look at the abdominal reflex, so this is umbilicus at the level of T10. If the lesion is here, this part will be present, right? This part of the abdominal reflex will be present. This part of the abdominal reflex will be lost because below the level of lesion, superficial reflexes are lost. So, this part of the abdominal reflex is lost. This part or the upper part is present. Okay. So, this differential portion of your abdominal reflex is a very, very important sign which we call as your Beaver's sign, which indicates that the level of lesion of the spinal cord is at your T10 level. Okay. So, here when we talk about, we are talking about the cord level. So, how do you demonstrate your Beaver's sign? So, when you ask the patient to lie down and get up, when he gets up, what happens? The umbilicus is shifted upwards because the muscles above are intact, the muscles below are lost, and hence the umbilicus moves upwards, and this is your Beaver's sign localizing to your T10 level. Okay. So, here again what will you have? You will have paraplegia. Your hands will not be involved, but your thorax from the level of T10 and below will be affected. Okay. Okay. So, this is about your localization to your thoracic cord. So, we have understood localization at your cervical cord, we have understood localization at your thoracic cord. Now, let us understand at the lumbar cord what happens. So, what will be the pattern of weakness? Again, you will have paraplegia. Okay. Then, lumbar cord L2, L3, L4. Let us look at the supply. Where is your L2, L3, L4? It is this part, right? So, it is predominantly your thighs. Okay, fine. So, what is the weakness at the level of L2, L3, L4? Okay, so the weakness is that there is loss of knee extension is lost. And which reflex will be lost? Your knee jerk will be lost because it is supplied by L2, L3, L4 at the level of lesion element, which will be exaggerated. Your ankle jerk, which is supplied by S1, which is below the level of your L2, L3, L4 segment, will be exaggerated. Similarly, if there is L5, S1 involvement, the foot and ankle will be weak. Can you see here? L5, S1. This is your L5, S1, right? So, foot and ankle will be weak. Ankle jerk will be lost. Ankle reflex will be lost. Okay. Knee jerk will be present because lesion is below that. L2, L3 is paired. So, knee jerk will be present. Okay. So, this is how you localize your lumbar cord. So, till now we have understood how to localize the lesion at the level of cervical cord, thoracic cord and your lumbar cord. Now let us move on to another very interesting and very strange syndrome that we call as the foramen magnum syndrome. We know that the foramen magnum is basically the opening in the skull through which the spinal cord arises and moves out, right? So if there is an injury that higher up, then what type of weakness and what are the peculiar features that you will find in this? So in the foramen magnum lesion, you will have lower cranial nerve involvement, which is your 9, 10, 11, 12 cranial nerves involvement. Why? Because of these cranial nerves also exiting through the foramen magnum. Then the lower end of medulla, can be affected, and hence the medulla has your respiratory centers. If there is damage to the lower end of the medulla, you can have loss of respiratory drive. Okay. Apart from this, you can have cerebellar signs, because just surrounding the foramen magnum, the structure which is present here is your cerebellum. There can be compression on the cerebellum and you can have ataxia as well. So in your foramen magnum lesion, a very peculiar type of weakness that we find here is called as your cruciate paralysis. Cruciate paralysis. Please do not confuse with crossed hemiplegia, that is in your midbrain. This is a different type called cruciate paralysis, a peculiar type of weakness. Okay. So what happens in your cruciate paralysis? Okay. So let us look at the arrangement of fibers within the lower end of the medulla where your pyramidal decussation is happening. In your medullary pyramids where the pyramidal decussation is happening, how do the fibers cross? So this is in your pyramids in the medulla. Okay. So you can see that the arm fibers, the fibers of the arms cross this way and the fibers of the leg cross more laterally. So the fibers which are going to supply the arm cross medially, fibers which are going to supply the leg cross laterally. Okay. So if there is a damage at the level of foramen magnum which is going to affect the crossed arm fibers and the uncrossed leg fibers, it is going to affect the crossed arm fibers and the uncrossed leg fibers, then you can see that here the right arm and the left leg is going to get affected. So you will have a right arm and you will have a right arm left leg. Very peculiar type of paralysis, right arm left leg paralysis called cruciate paralysis, which is seen in your foramen magnum syndromes. Okay, very clear. So foramen magnum is your uppermost part. So in foramen magnum syndrome, weakness can be cruciate paralysis, lower cranial nerve involvements, loss of respiratory drive, right, and cerebellar signs. You see that you never have, most often you don't have cranial nerve involvements in spinal cord disease because of cranial nerves are not arising from your spinal cord. So only in foramen magnum lesions you can get lower cranial nerves involved. Apart from 9, 10, 11, 12, you can also have spinal nucleus of the trigeminal nerve, because we had learnt in our brainstem syndromes as well that the spinal nucleus of trigeminal nerve extends up to the spinal cord and it carries pain and temperature. So you can have dissociated sensory loss over the face. You can have dissociated sensory loss over the face because of spinal nucleus involvement. The other nuclei are not involved. You can have dissociated sensory loss over the face, and this usually starts from the anterior part, which basically has an onion skin appearance of sensory loss. So it mainly starts from the anterior part and goes backwards, and this has an onion skin appearance of sensory loss in your foramen magnum lesions. Apart from that, involvement of the cerebellum can cause downbeat nystagmus, and you can cause obstruction to the CSF flow having hydrocephalus. Okay. So this is a very strange syndrome, foramen magnum syndrome. Each and every point is important. Okay, each and every point is important, and I've tried to explain the reason behind the same as. Now, let us understand the differences between a conus medullaris syndrome and a cauda equina syndrome. Okay, so conus medullaris versus a cauda equina syndrome. So conus medullaris is when the conus portion of the spinal cord is involved. As I told you, it has the spinal segment levels S2, S3, S4, and the cauda equina is basically involvement of the nerve roots, as you can see here, which come out as a bunch at the level of L2, L3 and below. Okay. Fine. So what are the differences? Now, in your conus medullaris syndrome, you have weakness, but it is usually a very minimal weakness and it is symmetric weakness, right? So, when it comes to the pattern of weakness in the conus medullaris syndrome, there is bilateral symmetrical weakness and it's very minimal because S2, S3 and S4, I will show you in this dermatomal distribution. You can see that S2, S3, S2, S3, S4 are predominantly supplying only these parts, right? So, predominantly it is supplying a very minor supply to the anal region, okay? So, you will not have much of weakness. What you have is a very minimal weakness, even if you have it as a symmetric weakness. But as compared to your cauda equina, which is your L2, L3, L4, right? So, this is going to supply your which region? It is going to supply the anterior aspect of the thigh and the muscles of the quadriceps. So, you can have an asymmetric, atrophic, areflexic. Why? Because this results in an element type of weakness. It results in a element type of weakness predominantly supplying your anterior aspect of the thigh. Okay. And because it is a nerve root involvement, it is an element weakness. But when it comes to the conus medullaris, because it is the spinal cord involvement, it is the spinal cord involvement. So, you will have an UMN type of weakness. Okay. Because it is the spinal cord involvement, you will have an UMN type of weakness. I hope this is very clear. Okay. So, in the conus medullaris syndrome, you will have very minimal weakness. Even if you have it is symmetric, it is UMN type. In a cauda equina syndrome, because the nerve roots are involved, it is asymmetric, right? You have asymmetric involvement, atrophic. Remember all the A's. Areflexic because element type of weakness. Okay. Then where is the sensory loss? You have saddle anesthesia. You have saddle anesthesia, right? The S2, S3 supply here, predominantly the perianal region. So, you will have a saddle-like pattern of anesthesia. So, many a times a conus medullaris patient will not even know that they have a problem. Okay, it is a walking patient because the weakness is very minimal. They are a walking patient. Also remember that the S2, S3, S4, this is the region, right? S2, S3, S4 is also going to supply your bladder. So, they are a walking but dribbling patient. They are a walking but dribbling patient. So, they can have urinary incontinence and they can have urinary incontinence and they can have fecal incontinence because the muscles of the anal canal, the bladder sphincter, all of it can be affected and you have anesthesia around it. There can be loss of pain and temperature around the S2, S3, S4 region. It is called as a saddle anesthesia. So, this is a walking dribbling patient. Remember this very clearly. Okay. The sensory loss for cauda equina, it is around the L2, L3, L4. So, it is predominantly along the anterior aspect of the thigh. When it comes to the reflexes, right, S1 will be present, S2, S3, S4 will be lost. So, what type of reflexes will be lost? The bulbocavernosus reflexes in a male patient or the bulbocavernosus reflexes will be lost. Okay, in a cauda equina, the knee jerk will be lost because L2, L3, L4 is your knee jerk roots. That is lost, but your ankle reflex is present. Okay, fine. And so, hence, early bowel and bladder involvement is found in your conus medullaris, which is not there in your cauda equina syndrome. So, I hope it's very clear. If you understand the concept behind conus and cauda, it's very easy to differentiate between the. Okay, fine. So, remember, walking dribbling is conus medullaris, asymmetric, atrophic, areflexic is your cauda equina. Fine. Now, we will move on to the next chapter, which is a part of your spinal cord itself, and this here we will enhance our understanding on compressive versus non-compressive myelopathy. Okay, we will enhance our understanding on compressive versus non-compressive myelopathy. So, whenever we speak about spinal cord disorders, we divide it into compressive versus non-compressive. Compressive means there can be a tumor, there can be an abscess, there can be anything, maybe a bone fracture or a bony deformity in the vertebral column which is causing compression of the spinal cord. Non-compressive myelopathy means there is a problem within the spinal cord which does not cause compression of any of the tracts, but it causes damage to the fibers. This is called as a non-compressive myelopathy. So under the compressive myelopathy, let us understand the etiologies, right? So we have epidural, intradural or intramedullary neoplasms. Okay. So what are those neoplasms? We will see. So epidural, intradural, intramedullary neoplasms. Presence of epidural abscess, right? Where do you get this? In your port spine or TB of the spine, tuberculosis of the spine, you can get epidural abscesses. Epidural hemorrhage. When do you get epidural hemorrhage? For example, in your road traffic accidents, right? Then cervical spondylosis, very common feature of cervical spondylosis is that you have neck pain and they can have some kind of sensory disturbances, and if very severe they can have weakness as well. Cervical spondylosis, one most common cause of compressive myelopathy. Presence of a herniated disc or post-traumatic compression by fracture, displaced vertebra and so on. Okay. Another very important vascular causes is your AV malformations. Remember, AV malformations on an MRI will mimic a non-compressive myelopathy. You might consider that to be a multiple sclerosis or an immune-like lesion, but it shows the presence of something called as flow voids, very important, flow voids on the MRI. So AV malformations in general can cause compressive myelopathy, especially if there is a bleed into the AV malformation, it is going to accumulate, cause a hematoma and cause compression. Then APLA syndrome, hypercoagulable states, all of these can cause bleeding and hematoma formation in compressive myelopathy. Then how do you remember the causes for your non-compressive myelopathy? You remember it with the mnemonic vitamins. So this is your mnemonic for the causes for non-compressive myelopathy. Right? So how do you remember it? Remember it as vascular, infectious, trauma, autoimmune, metabolic, idiopathic, neoplastic and syndromes. Okay, fine. So what are the inflammatory causes for non-compressive myelopathy? Remember, multiple sclerosis, NMO spectrum disorders, autoimmune disorders can also cause myelopathy like sarcoid, SLE, Sjogren's and other paraneoplastic conditions as well. Then infections which cause non-compressive myelopathy, right? Infections very important. Varicella zoster, herpes, CMV, HIV, HTLV. HTLV causes something called as tropical spastic paraparesis. Okay, so HTLV causes something called as tropical spastic paraparesis. Okay, right? So HIV in itself during its seroconversion period can cause a type of non-compressive myelopathy. Okay, and HIV in its chronic form can cause a non-compressive myelopathy which is called as vacuolar myelopathy. It is called as HIV vacuolar myelopathy, which is similar to your B12 deficiency. Then other bacteria like syphilis, listeria, borrelia. What does syphilis cause? So syphilis predominantly affects which columns? It affects your posterior columns, and this is what we call as tabes dorsalis. It causes tabes dorsalis. Then mycoplasma parasites, all of them can cause a form of non-compressive myelopathy, right? Apart from that, we have B12 deficiency which causes subacute combined degeneration of the spinal cord. What is the meaning of combined? Two tracts are involved, the corticospinal tract plus posterior column. Corticospinal tract plus posterior column. So you will have a type of spastic ataxia, right? You will have ataxia which is predominantly a sensory ataxia because of posterior column involvement. You will have spasticity because of corticospinal tract involvement. This is your subacute combined degeneration, and HIV vacuolar myelopathy is also similar to this subacute combined degeneration. Others include your copper deficiency and vitamin E deficiency, hypocupric myelopathy, vitamin E deficiency. All of these have a similar presentation. Okay, fine. So this is about the various causes for non-compressive myelopathy. So we have understood what is compressive, what is non-compressive and the various etiologies. Okay, amongst the non-compressive myelopathy, never forget your hereditary myelopathy or syndromes. Okay, so that is another cause. Alright, clear. Now, always remember that anything in neurology, you always need a localization. Apart from that, you need a time frame, right? You need a localization, but apart from that, you need a time frame. Whenever we spoke about stroke also, we told that It is acute onset, subacute onset weakness. Okay, so we spoke about different types. Acute onset weakness in the stroke, subacute onset weakness can be tumor, and so on. Right, so even in your spinal cord lesions, we need to talk about localization, we need to talk about time frame. So sudden onset weakness in the space of a spinal cord disorder can be because of a trauma. It can be because of an infarct. If there is a sudden embolus into your spinal arteries, then you can have a sudden onset weakness. In trauma, in infarct, if there is an embolus into the spinal artery. Also, in cases of aortic dissection, the dissection can extend up to the thoracic cord. If it extends up to the thoracic arteries, the direct branch is your artery of Adamkiewicz. If that is involved, you can have paraparesis. Okay, then bleeding into a tumor or bleeding into an AV malformation, all of these can cause sudden onset paraparesis or sudden onset weakness in a spinal cord. Then acute progresses within hours to days. Sudden onset, there is weakness within minutes. So most of the time, vascular or trauma is the most common cause of sudden onset weakness. Acute weakness progresses from hours to days. It can be because of transverse myelitis, where there is an immune-mediated complete transection. There is a immune-mediated complete transection. We will not say transection because the spinal cord is not cut off. Immune-mediated complete involvement of the spinal cord. Then presence of hematoma and abscess usually progresses over few hours to days, and hence you can have a subacute onset weakness. Subacute usually goes on from days to weeks. Subacute weakness usually goes on from days to weeks. It can be because of multiple sclerosis, pot spine metastasis. Chronic weakness is usually goes on from weeks to months. This can be spondylosis and hereditary neuropathies, nutritional disorders, infections like TBs, then subacute combined degeneration, then your spinocerebellar ataxia. SCA is a type of inherited disorder like spinocerebellar ataxia, or your motor neuron disease. MND is motor neuron disease. So this can result in a chronic weakness, right? So anything in spinal cord is localization into time frame. Sudden onset is often vascular or a accident causing trauma. Acute is hours to days, subacute is days to weeks, chronic is your hereditary neuropathies, it can be your tabes dorsalis or your motor neuron disease. So this is about your time frame in spinal cord weakness. Now let us understand what is your compressive myelopathy. Let us understand what is compressive myelopathy. We understood the etiologies. Let us look at it a little bit more in detail. Okay. So compressive myelopathy can be classified as extramedullary, extradural. So compressive myelopathies can be classified as extramedullary, extradural, or intradural. Okay, extramedullary, intradural, within the dural cavity. Extramedullary, extradural, as you can see here, this is your spinal cord, this is your vertebral column, this is outside the dura mater as well. So this is your extramedullary, extradural. This is outside the medulla, this is outside your spinal cord, but within the dural cavity, extramedullary, intradural. And this is your intramedullary lesion. This is your intramedullary lesion. So compressive myelopathy can be classified as extramedullary, extradural, extramedullary, intradural, and intramedullary lesions. Okay. So I hope this is clear. What is the examples of extramedullary, extradural lesions? Metastasis, TB spine, spondylosis. Extramedullary, intradural lesions are neoplasms like meningioma, schwannoma, neurofibroma. And intramedullary lesions, very simple, syrinx and ependymoma, because ependymoma and the CSF flow is in the center, so ependymoma and syrinx. Okay, so this is about the different types of compressive myelopathy. Now let us understand the clinical features and differences between your compressive versus non-compressive myelopathy. Okay, fine. Now we have understood what are the different types of compressive myelopathy. Let us see the clinical features. Compressive myelopathy will have pain, because whenever there is a compression, what will happen? It can result in pain. right? So what type of pain will you have, right? You will have local pain in what type of lesion? So if there is a compression here, as you can see at your vertebrae, if there is a compression on the vertebrae, in your extramedullary extradural lesions, you will have pain on that vertebrae. That is called as your local pain, which is seen in your extramedullary extradural, like your metastasis and Pott spine. Radicular pain. What is the meaning of radicular pain? Radicular pain basically refers to a sharp lancinating pain which is present along the dermatome, where that particular nerve root or radicle is supplying. Sharp lancinating pain along the dermatome where that particular nerve root is supplying is called as your radicular pain. Where will you get your radicular pain? In which type of compressive myelopathy? We know that the nerve roots are going to come out from here, right? The nerve roots are going to come out from here. So if there is a compression here, or let's say anywhere here. So in an extramedullary but intradural compression, intradural, intradural compression, you will have radicular pain. So in a compressive myelopathy, you can either have a local pain or you can have a radicular pain, depending on whether this is an extramedullary extradural lesion or an extramedullary intradural lesion. So in your non-compressive myelopathy, you usually do not have any pain. Okay? In your intramedullary lesions, there can be compression onto the tracts depending upon the extent of expansion of the lesion, and you can have a dull aching pain which is found below the level of lesion, which is called a tract pain or a funicular pain. You can have a funicular pain. Okay, so in a compressive myelopathy, you can have pain. Non-compressive, you do not have pain. Deformity like a gibbous or a kyphoscoliosis. Okay, these kind of vertebral deformities are seen in compressive myelopathy. Gibbous is seen in TB spine. You do not have deformities in non-compressive myelopathy. Then pattern of weakness. Pattern of weakness is often asymmetric, right? Because it depends on which part of the spinal cord is getting compressed. If you have compression from one side, the other side is not going to be affected. So asymmetric weakness in your compressive myelopathy, but in a non-compressive myelopathy, because there is inflammation symmetrically inside the spinal cord, you will have symmetric weakness. Okay, bowel and bladder involvement will be late in your compressive myelopathy depending upon the type of compression, but it is not very frequent. Bowel and bladder will be early in your non-compressive myelopathy. Okay, selective tract involvement is present in non-compressive, it is not there in your compressive. So these are the major differences between compressive versus non-compressive myelopathy. Then very, very important and often considered to be quite confusing is the difference between various types of compressive myelopathy itself. So how is an extramedullary extradural lesion different from an intradural versus an intramedullary compressive myelopathy? Extramedullary extradural, what type of pain they will have? Just now we had discussed, they will have local pain. They will have local pain on that particular vertebra. Intradural lesions, intradural extramedullary lesions like your meningioma, schwannoma. What comes out in that intradural space is radical, so you will have radicular pain. You will have radicular pain. How do you define radicular pain? It is a sharp lancinating pain. Sharp lancinating pain along a particular dermatome, okay, and this increases with conditions where there is an increased abdominal pressure like coughing, okay, and it is relieved on bending forward. So that is your extramedullary intradural lesion. What type of pain in intramedullary lesions? You will have funicular or tract pain. Tenderness will be there in extramedullary extradural. Yes, metastasis, Pott spine can all cause tenderness. It's not there in the others. Then extramedullary extradural lesion will have early corticospinal tract involvement. right? It is early in your extramedullary, extradural and intradural, but not in your intramedullary. Okay, fine. Why? Because the corticospinal tract is present here and compression will directly affect it, but not so in your intramedullary. Okay, then let us look at the sensory loss. To understand this, so this is an extramedullary extradural lesion. Which will be affected first? We know that the sensory loss, sacral sensations are affected first. Sacral sensations are affected first and cervical is last. That means sacral is lowermost, cervical is above. So you have an ascending type of pattern. You have an ascending pattern of loss. Okay, fine, right. But in your intramedullary lesions, the sacral sensations are spared. So this is called as sacral sparing. So this is called as sacral sparing, which is seen in your intramedullary lesions. Okay, then what about the bladder involvement? I told you, do not confuse yourself with the sacral sensations versus your bladder involvement. Okay, so the bladder sensations are present more near the intramedullary lesions, right? So intramedullary lesions will have early bowel and bladder involvement. They will have early bowel and bladder involvement, but here it will be late because by the time it reaches here, it takes time, right? So late bowel and bladder in your extramedullary, extradural, intramedullary lesions, early bowel and bladder. Okay, fine. So with this, we have come to the end of our chapter on approach to spinal cord. I've tried to break down into simpler topics. Of course, it is confusing. So whenever you find it confusing, please go through the chapter again and try to examine patients and try to understand, because unless you examine a patient, you will not know how the differences look. How is UMN? How is LMN? What are the differences? Right? And try and take a clear, good history, type of pain in a spinal cord lesion. What type of weakness? What was the pattern of weakness? Was it ascending, descending? How was the bowel and bladder? So this makes your understanding of approach to spinal cord disorders more easy. Thank you.